Hello, and welcome back to another episode with Health Without the System. My name is Mia Scott, a nurse practitioner, and typically you guys are used to my husband, Tim Scott, as my partner in crime on this podcast, but today we have a very special guest and an episode that I am so incredibly excited for, and one of my favorite providers that I collaborate, if not weekly, at least probably daily at this point. So please welcome Brandy Secory.
Hello. Thank you guys for having me. I'm so excited to be on this podcast. I listen every week and I'm just in love with it. So thank you.
Awesome. Well, welcome. It's great to have you. Get a little bit of a background here with Brandy. Her and I, if I do the timeline right, I think it's probably over 9 years now that we've known each other. And her and I both have an emergency medicine background. That's where we started, way out in the boondocks in a little local ER. And she became one of my probably biggest mentors. I don't know if I've ever even told Brandy this, but she was definitely a provider who I've really looked up to, watching her with her patient care, being an advocate for patients. ER, if anybody worked or has been into the ER, you know how chaotic things can be. And sometimes providers can be, I don't want to use the word heartless, but a little bit dismissive. And what I loved about Brandy's care is she was always so thorough, no matter what it was, that she really took her time to dive into making sure that all the patient's needs were addressed and all the things. So she became my mentor mentally, and every single shift that I worked with her, there wasn't a single shift that I didn't learn something, and she really inspired me. And then when I started to go to school for nurse practitioner, she was actually one of my clinical guidance instructors that helped me when I did clinicals and rounds in the ER. So we go way back. And then flash forward to now, where she is full-blown doing hormones and all the things, which now I'm dabbling into as well. So she's been a mentor for almost a decade, and it's wild to say. So, but let's just dive in. So we're going to start with saying it is October. We barely got the cutoff here as the end of October, but it is Menopause Awareness Month. And this is a topic that, as I say with any topic, we can talk for probably days, weeks, months about this topic because it's so complex. But we're going to dive into what peri and postmenopause looks like for patients, some of the misconceptions, some of the things that we find our patients struggling with often, lacking a big gap in care with this, and we'll touch on some men's hormones as well. But let's just dive in. So first off, Brandy, how and why did you decide to go down the hormone path and start your own business and do this every single day?
Well, thank you for saying all those kind of things. You've never shared that with me. So that's so sweet. And I love that. And I do try really hard because I'm passionate about being a provider. And I think all providers are. I love that Tim and Mia always say it's not the provider, it's the system. And it really truly is, because I don't think anybody picks this career path without an empathetic heart and a willingness to serve others. And so it's honestly by pure accident that I stumbled into hormonal health. I was working ER full time and had a lot of lifestyle changes that needed to be addressed with husband and kids and things. And so I started working at another clinic doing hormone replacement therapy, and I fell in love with it. I honestly didn't know the first thing when I got started. I took class after class, and now I just basically turned nerd over it because I'm just so obsessed with just learning more and more. And now also, like, thanks to you guys, like learning more about functional health too.
Yes. They go hand in hand. And that is exactly where I stand. And if for any of you previous listeners, you know that when we first launched our wellness clinic, it was specifically around weight loss and metabolic health. But then within that, you have all of these things that you cannot ignore that patients are suffering with. Number one, first and foremost to me, which many of you guys know, was thyroid. When you have patients that can't lose weight and they're complaining of all these symptoms and and they're doing everything right, you have to look at some hormones. And then within that, I'm like, listen, thyroid's a hormone. What else am I missing? And then I would get these patients that would have a slew of complaints that I'm like, what am I missing? And it wasn't until we started, I would collaborate with you and say, do you think this could be hormonal? And you're like, absolutely, this is what we see, XYZ. And it really, that was like the sparking or the tipping point that I'm like, okay, now I need to assess hormones because that is also inhibiting my patients from thriving, especially obviously women. And majority of it is women, as we know. So yeah, it's been a crazy journey the last few years. So, and then you have your local practice here. How long have you been open now?
Almost 2 years.
Okay.
So, yeah.
But then before that, you worked at a facility or another clinic, not your own, and did a few years there as well.
Correct. Yeah. So, and that's kind of where I fell in love with it. And it's just awesome to see these patients' lives change. They come literally in misery. And by the time you've been with them 3 to 6 months, their whole lives are turned around. They feel so much better. they feel heard more than anything. So I think if I could give any word of advice to other providers, don't be dismissive about their perimenopausal or menopausal complaints, or even if they're aging male, absolutely listen to their patient.
Yes, exactly. All right, so let's talk about why do we not see very many women on hormones as every single day when we have these complaints? Because Brandy and I, of course, we're not primary care, so we have our own practice, and we see these complaints that we're like, have you talked to your PCP about this? And they're very dismissive. So why do we feel, or you or I feel like that many women on or not on hormones this day? Why is there such a gap in this care?
I think the two biggest things would be stigma and fear that surround hormones. We're taught in school not much about hormones, if we're being honest, because of a Women's Health Initiative study from 2002, it sparked a lot of fear, debate, and then stigma from then on regarding hormones. And so I think that most clinicians are taught that it's bad and we shouldn't be prescribing it. I know that's what I was taught. And so I had to relearn and re-educate myself. So
yeah, and life is busy and we just fall into this algorithm and go with the flow type thing, especially when you haven't been taught things in school. And if things are foreign or feel uncomfortable, it's, well, I don't know about that. I'm not even going to try to learn. But it wasn't until, like you said, the Women's Health Initiative, where you start to read these things where you're like, that's really not, it wasn't a great study, and we'll get into that as well. But there's just such this fear, and because of that, there was 20 plus years where females have gone without hormones. I think it was probably within a few days of that study, I think it's 70 or 80% of hormone replacement therapy was discontinued, which is wild, because now we're seeing that effect. We're seeing osteopenia, osteoporosis, dementia, lipid cholesterol issues, brain fog, all of urinary issues that could be prevented. And we're seeing that happen because of this gap in hormone care. So yes, like Brandy said, stigma, fear, and then this massive gap in education. Because I know when I went to school, I mean, it was perimenopause and menopause will happen to every female, of course, but that was pretty much the line in the sand, and we really didn't go much further. And so that's why I feel like a lot of these patients, they either get dismissed from PCP, tell them that it's normal, or they just don't get hormones at all because these providers they're not taught it. And it's crazy. The last few weeks, we've even had referrals from OB to come to us to get hormones. And that's great that they're actually reaching out to resources. But look at that gap in education, where even OB offices who should know day in and day out hormones, they don't even feel comfortable prescribing. And that's just a massive gap in the system, which we talk about often. So let's just dive in as well on what exactly is happening during perimenopause. I know that that's something that we throw around that term often. We know it's a massive gap of how long that can be, but what exactly do you see happen in your patients when they say, or when you're assessing them for perimenopause issues?
Yeah. So perimenopause is hard. Honestly, it's probably the most difficult thing I deal with women in my practice. It can be up to 10 years before menopause, honestly.
Yeah.
And so it can have a plethora of symptoms that are literally changing all throughout the month. If you would track the hormonal decline in the female from the time they're 20 to 40, you would see the levels going down. But between that, you would see estrogen and progesterone going like this.
Right.
And so, yes, there's overall a hormonal decline, which is causing a lot of the symptoms to be occurring, but they also have peaks and valleys of estrogen and progesterone that just cause a plethora of symptoms.
Yeah, it's not like a consistent low, like when which we'll talk about when we get into postmenopause, where it's basically like depletion, everything's done and the follicles are done. But when you talk about perimenopause, that's why I think, unfortunately, that's where the biggest gap is, because you'll have patients come in, and I hear this a lot. Oh, they told me I was too young for perimenopause. And these patients are 44 plus or even younger than that and miserable. And that's because, like Brandy said, it's fluctuating. It's not, and you've taught me this many times, where when you draw hormone levels, that's a very quick snapshot in time. That is right then and there. You might not be that next week or even the next day. Yep. So that's why you can get these massive fluctuations, and that's what can make people absolutely miserable during this state. And I'm sorry, but who wants to go through that for potentially 10 years without having some type of guidance to say, this can't be the answer. Nothing can be how do I fix this? So, and we'll address what that looks like and what we can do. But then let's talk about what happens during postmenopause after peri is done.
Yeah. So postmenopause is honestly way easier to treat, and that's essentially just ovarian decline or almost ovarian death, which is very interesting when you compare the men and the woman, because we are very two different human beings, obviously, and it's so important that we learn the other person too, because it helps us in our lives in so many ways. But women go through menopause, and essentially they have ovarian death, and their hormones literally are done. Essentially, their reproductive hormones, the potent ones. There are more than just the big ones, but estradiol, E2, and progesterone essentially are very, very not present at that point.
Yeah.
They're not going to release any more eggs. And so that either happens when a woman has reached no menstruation for 1 full year or surgical menopause.
Surgical, yeah. So surgical menopause would be like a total hysterectomy or maybe even a hysterectomy. Maybe they've left ovaries, but that is especially the total. It's a complete shut off. You're done. It ripped it out. And then the next day, boom, you're in menopause. And that brings me to my point real quick that I will have patients because it's you're going shopping for a car, you want a red car, and all of a sudden you see red cars everywhere. So now with my patients, when I assess and I'm listening to them and listening to their complaints, and then I peek up and see their age, and I'm putting all this together, and especially my patients that have had total hysterectomies at a young age, I'm like, did anybody replace your hormones? No, they said it wasn't needed. I'm too young. And I'm like, but you had a total hysterectomy immediately. It's like you ripped off the Band-Aid, boom. Did you feel terrible? Well, yeah, it was the hardest thing I've ever done, but now I'm just used to it. That is the gap in care that we're also talking about as well. It's not just a natural aging process. We have a big population that basically has to go through this surgical menopause for whatever reason. There's multiple reasons that could happen, and they're not being appropriately replaced with bioidentical to support them, not only during the time that is most crucial for them in their younger years to feel better, but longevity. And that's what I think that has really sparked my interest in this world in general, because it's not just like a PCP would say, well, if you feel fine, we're not going to touch anything. We're not going to do anything, because you will have lots of postmenopause patients who say, well, it was easy. I sailed through it. I'm fine. But what about long term? What about protecting yourself, protecting your bone density and your muscle mass and your brain fog and your cognition? And if you have a corporate job, are you going to be able to remain in that role because your hormones are just gone? And we actually hear about that often. Just the patient I had yesterday said, I would have got fired from my job if I didn't get on hormones, because it's that much of a life-changing factor for patients. So there's multiple categories, but peri or postmenopause and surgical menopause, essentially the same thing. You're done with hormones, and you can really feel that. So what do you typically see in patients with low estrogen, or what are some of the complaints that patients say to you that immediately think, yeah, you're probably low estrogen or fluctuating?
Yeah. So I think the classic one that everybody equates to menopause is hot flashes and night sweats. That might be the most common one, but honestly, there's so many others. And so countless things, and the most randomest weird things that you could ever imagine, you know, like itchy ears, palpitations, vaginal dryness. I mean, there's a ton, but mood is one, anxiety, depression, irritability, fear from really like an unknown source, and they haven't been this way before, low libido, like I mentioned, palpitations, brain fog, fatigue, forgetfulness, that loss of concentration. Long term, like you said, definitely like risk for dementia, osteoporosis, cardiovascular disease, and general urinary symptoms. So
and that just brings up another case. We're all about cases today, but that brings up another. I had a patient come to me, and actually she wasn't even a patient, she was a friend, and she messaged me and said she's never had this before. She's 56 or something, and she had just full-blown panic attacks, had no idea why. I've never had panic attacks in my life. I'm afraid to go in public now because I've never experienced this, and I've never want to do it again, but she's had multiple. And she's right in that age, and she just hit postmenopause. Oddly enough, she felt like she had that smooth transition, and boom, and now she's feeling terrible. And her doctor, of course, is wanting to put her on SSRIs. And not to shame SSRIs, mental health is absolutely needed and supported. However, it just blows my mind that these providers don't assess. Look at your age. Look at what you're telling me. This is likely hormonal. Let's try to address it on that side first. And if we need to touch in SSRIs, we can do so, because most medications don't come without some type of risk panel, obviously. And I see way more harm done than good with SSRIs, because now you have brain fog. I hear all the time, I'm living in this mental state where I'm like, I don't feel like I enjoy life. Yes, I'm not having panic attacks, but my life is just take it or leave it. It's blah. So you have to look at really being an advocate for yourself, because some of these symptoms, like Brandy is saying, they're not common. You'll get a referral to cardiology for heart palpitations. You might get on metoprolol or something like that, and nobody has ever assessed, well, do you actually need hormones? Is it a hormonal issue? So we definitely see that too. And then as there's multiple forms of estrogen. So why don't you dive into a little bit of how many, and we don't have to just get super scientific-y, but the few forms of estrogen and what that might look like in different periods of life.
Yeah. So when you hear your provider say estrogen, there's actually 3 forms of estrogen in the body. We call them E1, E2, E3. And so E1 is estrone. That's the more dominant form of estrogen after menopause. And so that one's mostly in our fat tissues, and it comes from the aromatase process, the conversion of androgens into estrogen. And so it's a weaker form of estrogen. Estradiol, E2, is the more potent form of estrogen. That's our reproductive estrogen. And it's the most potent and active form within the body. And so that's the main one that we focus on during like hormonal replacement. But sometimes we also use estriol, which is E3. And so E3 is more of the gentle form that actually more involves pregnancy. And so primarily we're working with E2 estradiol, but there are 3 forms, you should know that, and that makes up our total estrogens.
Yep. And just to touch on the E1, I know that that's linked more to like potentially cellular or cell proliferation or essentially potential cancer growth. And I know that sounds scary for some, but that also has a lot to do with how you metabolize things as well. And Brandy and I have talked about this just briefly on some other resources that we can do. I'm functional medicine based. And in my functional medicine training, outside of just my hormone training, I did a second training with the Dutch test. And that was super cool to see your metabolites. So not only can we watch what's happening on lab levels when you are taking, whether that's a patch, whether that's oral, whether that's pellets, whatever that looks like for somebody with these bioidentical hormones, you can actually watch what's happening when they come out of your body, watching the metabolites. And you have these pathways, which we're not going to get into today because my Lord, is that a podcast? But it basically can tell you what pathways might need support through your phase 1 and phase 2 detoxification. It can tell you if you're pushing more or you're metabolizing more of an E1 versus which is potentially the more dangerous one metabolism wise. So it's not to say that hormones are bad at all. I absolutely fully diehard support hormones, but once again, coming from my functional medicine standpoint, you have to make sure that the body is supported as a whole. How is your thyroid? How are your detoxifying properties? How are your day-to-day life activities? How's your liver function? These are all things that we can help our patients to have not only a better transition, but make sure that they're safely getting and excreting metabolites. And that is not just with hormones. That's with any toxin that you want to make sure that you are excreting appropriately, because as we know, toxins build up and then that's no bueno. So why does this matter in peri and post-menopause? As we said, as ovarian estrogen fluctuates and declines, then that's where you really see these flip sides of hot flashes and things like that. So really want to make sure that we're addressing that with your provider, or find somebody like Brandy who can help you as well. So we talked about what do we see with low estrogen. Now, this is a really long section that I'm just going to skim over here, but just name a few things that what does estrogen do or help to the body? And this isn't just bioidentical. This is like your own natural estrogen. What does this do for patients? Mind you, it's also in males as well. This is not excluded to females. Men also have estrogen. So what does estrogen do to the body?
Yeah. All kinds of wonderful things, if we're being honest.
Yeah.
And we've had it our whole lives. And so it's really a problem when we don't have it anymore.
Yeah.
Or enough of it, I should say. But it affects literally almost every organ system. So you can see positive results in every single system: heart, bone, brain, your endocrine system, of course, your urinary system, skin, hair, nails, your immune system even, and your nutrition overall.
Yep. And it's exactly like you said, heart and blood vessels. So that's why you can get some of these palpitations as well with the fluctuation in hormones. Something that I see very often now that I'm aware of it, is a shift in lipid profile. And once again, I will get these patients that they're coming to me for weight loss because they're stagnant in their journey. They want to assess and to take a deeper dive into these things. And oddly enough, they're like, I've had a cardiologist. They want me to take a statin. I don't want to do it. Or they've tried a statin and they've had too many side effects. And I'm like, have they checked your hormone? Where you stand in your cycles here? Are you peri or are you post? Because that we definitely see a pretty decent lipid shift for some. And that's a big red flag to say, why don't we address what's missing versus statins, which have their own slew of problems in itself. So something that I hear often for patients that come into me already on some type of bioidentical replacement, and they say, well, I was told that since I don't have a uterus, I don't need progesterone, and their providers won't give that. What are your thoughts on that? And do you see that in practice if you're assuming care from somebody else?
Yeah, I have seen that also. Progesterone is super important. I really think it's very important that we understand that estrogen and progesterone need to be well balanced for the benefit of the patient. And so if we have too much estrogen and not enough progesterone, we become estrogen dominant. That can cause a lot of symptoms to occur. Weight gain being the one primary one that no women want.
No.
And so we're already struggling with that once we hit our 40s. And so we don't need to add to that problem. But progesterone is a wonderful thing for us, and it does so many things. Like the two top things would be mood and sleep that progesterone does. It does more than that, but those
Yeah.
for sure it helps with.
Yeah. And there's receptors all over our body. So when I hear that, when I hear my patients say, well, my provider only gave me an estrogen patch, they told me that I was not a candidate for progesterone since I don't have a uterus. So for those of you who have that need that backstory, if you have a uterus and you're on estrogen or a patch or whatever that looks like, you need to have progesterone on board to protect your endometrium line or your uterine lining. Also, progesterone can help regulate bleeding and things like that for patients that we have very heavy periods or endometriosis and things like that. So it can help a ton. Like Brandy said, it is your go-to for sleep. It's a calming hormone. It affects your GABA receptors, and it's a very relaxing hormone. That is why we take it at night. And another story for you, I had a patient again who just yesterday, she was complaining of some symptoms. And first, when I addressed her age, I said, are you in postmenopause? Yeah, I'm in postmenopause. It was smooth sailing. Nothing was needed. No hormones were needed. And I said, okay, are you sleeping well? No, I don't sleep well at all. I haven't been sleeping well for a long time. Okay, are you having hot flashes? I don't have hot flashes, but I wake up multiple times in the night sweating. That is a typical form. So I'm like, listen, you have more symptoms than you think. You're just living in what you think is your norm, and that we can fix that. And she said, I can't tell you what I would do to have a better sleep life. And I'm like, these are the things that you have to dig down deeper, because patients, and I'm talking to you people listening, you guys will just think that this is normal and say it is what it is. And I'm just going to live like this because my PCP or somebody told me that this is just life. And you get used to that norm, and you want to be able to make sure that you're being heard and find the right people to address those things for you. So we want to normalize having that smooth transition and giving our patients the best strategy of relief that we possibly can, safe and effectively, of course. So peri and postmenopause, we talked about what's happening. Estrogen in peri, estrogen and progesterone are fluctuating. It's not just low. Like Brandy said, common signs would be heavy irregular periods. We can see that shift. Maybe you were a 30-day cycle. Now you're slowly going down to 24, 26 days. And then maybe you start to skip a month or two, or maybe you have some more heavy bleeding and that wasn't normal for you. These are all signs to say you're likely entering that peri state. And I know that's crazy and scary to say, but remember, this could be a 10-year time frame, and things could potentially get worse with some of these symptoms as you go on and on. So, and I want to just address modifiable. So talk about, I'll get into my functional medicine speech here with some of the modalities that we can do to help support hormones as well. But when you have somebody who comes in for perimenopause, I know another stigma that we hear a lot is, I don't need hormones yet because I'm still having a cycle. So when you hear those patients tell you that and they're miserable, what is some of your treatment care that you do for them to help make them have a better steady state going through perimenopause?
Yeah. I think first is just knowing and being observant. Like, I think there's a lot of benefit to keeping a diary or journaling what's happening. Tracking your menstrual cycle is super important, because things are happening at certain times of the month. And if a patient can correlate that symptom with the timing, that can sometimes help me. Because in our premenopausal, progesterone is really only high after we ovulate in preparation, like during the luteal phase for for menstruation. And so then it declines during the follicular phase. And so it's important to know when the symptoms are happening, what symptoms are happening. They might be changing all throughout the month. And so as the 10-year span progresses too, their symptoms change like 3 different times. So continuously reassessing your patient, having the resources and the tools, which Mia's going to go over some of the basic foundational things that we need to do as women. I think that the other thing just to touch on is women are my favorite. I love taking care of men too, but obviously probably because I am a woman, but we are living in a society where we have careers, we're mothers, we're wives, we're doing everything. And even myself, you could easily disregard how you're feeling and just be like, it's just because I'm working so hard and I'm doing all the things. And I hear that countlessly from all the women that I see. And so just taking a minute to step back and realizing it's okay. We as moms especially we feel guilty to take time for ourselves, but we have to, because we will not be a better mom or a better wife or better performer at work if we don't.
Yeah. And I'm a huge podcast person, obviously. And I've heard a ton of people say, and guests on podcasts saying that we can't even believe how much it's impacting corporate world, and how because Brandy said, we are stretched so thin because we are everything. And hopefully you guys have a good support team like Brandy and I do here at home, but you have to make sure that you're taking that time, because if you have a hormone depletion and you get later on in life, that is quite honestly one of the biggest deciding factors of people leaving big stressful jobs that are not treated with menopause because they can't hormonally, they can't handle it. Like my patient that I talked to yesterday who said, I would have lost my job if I didn't find somebody to give me hormones. And that's sad to say, because not to say that men are treated differently, but they are. If you have a man that goes into your PCP office and he says, I have low libido, I can't get erections, they will be leaving with a Cialis or Viagra script that day. And here we are as females banging on the door saying, can somebody help us, make us feel better? And it's, I have no idea what you're talking about, or I wasn't trained in that. I get that so often. I'm not comfortable doing hormones, or they're so dangerous, which just really chaps me. So Brandy talked about some of the things we can do, and you've helped me understand that different cycles or different times, like you said, tracking, making sure that we're aware of some of these symptoms, but there might be some support that we can do within that. Progesterone a week before your cycle, whatever that looks like for that patient. Of course, all individual needs are individual, hence the personalized care. But there are things to do to make things better for you. And I'm not saying that every perimenopause person needs to immediately jump on hormones, because Brandy said, your estrogen is and hormones are going up and down and up and down. So if you have somebody on, you don't want to put somebody on these high doses of things, because when they're high peak, they're going to be even higher because you're putting them on hormones, which is what I love about Brandy's care, how she says, if we're tracking things, maybe we can do treatment just during certain days of the month to help ease through, to have a more steady state. So you're not like the dragster going up and down every single day of your life until you hit postmenopause. So we always talk about modifiable risk factors. Now, of course, modifiable is what you can personally change. Now, yes, there is genetic components to this, because I hear it often. I have endometriosis. My mom has endometriosis. My grandma, I hear that all the time from my patients. We've all had hysterectomies. There is some type of obvious underlying genetic component. However, as if you've listened to us, genetics is a loaded gun. Your environment and your epigenetics, meaning what you control in your lifestyle, is what is going to turn on and off those genes. Now, there's a lot of things that we can help regulate with our body. The sleep disturbance. If you're already at baseline of sleep disturbance, you can have greater sleep disturbance with hormonal dysregulation. Your chronic stress, that is going to affect your HPA axis. If you have high stress going into these states of peri and postmenopause, you can have worsening anxiety, you can have worsening of heart palpitations and hot flashes. So think about somebody who already has a baseline anxiety and is coming back to their doctor during this state and saying, I'm even more anxious. They're going to get more meds. They're going to get more anxiety meds. They're going to get more SSRIs. And instead of saying, actually, because you're already a baseline anxious person, this could have gotten worse during this time of your life. And those are the things we want to make all of our audience aware of, so you can change these modifiable risk factors. Another one, metabolic factors. I know I talk to Brandy every single day on collaborating with different cases. We go back and forth. I teach her about functional medicine. She teaches me about hormones. It's a wonderful collaborative care. And she understands the importance of some of these metabolic risk factors like insulin resistance. If you have more central adipose weight gain in your stomach or your belly area, you're going to be at higher risk for some of these changes that happen, especially your vasomotor ones. So your night sweats and your hot flashes and brain fog and fatigue. So there's certain modifiable risk factors that can set you up to have a much worse transition into a postmenopause state. Another one, smoking, high alcohol, and high caffeine. And I'm not the first to tell you that alcohol is a poison. I just wouldn't do it. But those are the things that we can absolutely address, because this could make your phase better to transition into. Muscle mass. Lifting weights. I preach this every single day to my patients, and lift heavy things, females. It regulates hormones. It can make you more stable, meaning not having so many ups and down fluctuations. So there's so many things that we can do for that. Of course, micronutrient gaps, low vitamin D, magnesium, omega-3s, looking at your iron. This can all correlate with these mood, fatigue, and muscle mass issues. Liver, huge. You have to make sure your liver has been able to metabolize some of these things. If you have constipation, you're going to have a reabsorption of some of these estrogens that your body is trying to excrete. Remember, waste is a toxin. You want to get that out. So making sure that your liver and your gut are good. And then, of course, talking to a hormone therapist or specialist who can help you navigate a whole entire lifestyle approach. So that is the big speech there. So let's dive into some postmenopause patients. That's, of course, like you said, 12 months without a period. Symptoms can still persist. Now, I know you said that perimenopause patients are like one of the worst to treat because of that fluctuation. When it comes to postmenopause patients, what are your standard things that you see? Because honestly, they're postmenopausal, so they're still coming to you with these symptoms. What are some of those things that you still see with untreated postmenopause patients?
Yeah. So all women are different. So some women do go through that rough page of perimenopause. Some seem to breeze by, and like you said, maybe that's their perception more than anything. But
Sure.
some women honestly will never get rid of their postmenopausal symptoms. And so that's just devastating, right?
Yeah.
You're talking living decades, feeling like crap. No
Right.
thanks. So I think that it's different for every woman, but the main things that you're going to see are detrimental to our health and all the things that we don't want. Osteoporosis, risk for fracture. Working in emergency medicine, it only takes you to see a couple hip fractures in an old lady and realize I don't want to have that. Or the demented old lady. And we're losing our cognition in our brain, and our nursing homes are filled with elderly females. And you have to wonder if it's because they didn't have hormones. And so I think it's really, really important. But that postmenopausal patient, one thing that I wanted to add earlier that you said is that you might not be needing it during perimenopause. There is an ideal time. You don't want to obviously start hormones when you're 70 or 80 years old, most likely. So for the most people, that's going to be between 40 and 60 at or around the onset of menopause. So the sooner you intervene, typically at around menopause, the better off you're going to be likely because you're not having that loss of hormone for a prolonged period of time. And then you have to restart everything.
Yep. And just to touch on that doesn't mean females are listening who are like 61. They're like, oh man, I just missed it. You can still do it. We obviously have to look at other risk factors in general, but this goes back to fear mongering and being able to provide true informed consent, because we know that even, which we'll get into, the synthetic hormones, that carries a higher risk profile than some of these bioidenticals, than all of the bioidenticals. Yet we are so fear mongered over that. Yet we will prescribe birth control like it is freaking Skittles. I have 60-year-olds on synthetic birth control, and I'm like, what are we doing here? But they're scared to death of bioidentical. And I'm like, this is so backwards because that lack of education. You're at greater risk for clots, greater risk for mood swings and changes on this synthetic, greater risk for migraines and auras and things like that we can be hopefully preventing on a more bioidentical form. So yes, it's very interesting to see that. So let's talk a little bit about labs. And I hear this all the time too. My PCP told me my labs are normal, but why do I still feel awful? You've touched on this, the fluctuation. So why don't you tell us a little bit about some of those patients that you have that might look okay on labs, but presenting a completely different story?
Yeah. You mentioned it before. Hormones are literally a snapshot in time. It's no different than when we take the EKG and the ER. Well, there's no sign of heart attack on this EKG right now. This is a snapshot in time. So it's important to trend the labs. They touched on this in the very beginning, trending your labs. Please learn stuff on this podcast. Trend your labs yourself. Your family doctor might not have the time to trend your labs. So you need to know where you're at in your menstrual cycle. You need to know what has my progesterone and estrogen been doing. And then can you correlate a little bit further with the symptoms that you're having? So the timing of the lab is important. Optimal and normal on your reference range are two different things.
Exactly.
And honestly, because of the lack of research and education surrounding hormone replacement therapies, we don't have a lot of great data, like solid data that says this is the optimal range. And so you'll see things practiced very differently in hormone replacement therapy.
Yeah.
And that's medicine in general, but that's also what makes it awesome. You know what I mean? But just because your labs are normal doesn't mean that you're not having a problem. That's really important that we address that. And also the reference ranges change with time. And so they're really more of reporting a sample size, not what's optimal for the body.
Yeah. Exactly, because they're a snapshot in time, but trending your labs, and that goes for everything. Ask your provider to run a fasting insulin and A1C, even at a young age, because you can trend those. Because remember, that is your journey, that is your data. If you wear an Apple Watch, if you have an Oura ring, it's just like that. You want to add in labs with that to make sure that you're trending your data, because things will shift and you can see that and potentially feel that, of course, as things go on. And there's so many things that we're missing. Quick story. Yesterday, I had a follow-up patient on somebody who was being treated for thyroid, mismanaged, of course, very symptomatic, comes to me. I get my panel of labs. She's insulin resistant. They never did a fasting insulin. Her reverse T3 is through the roof. She's blocking her thyroid hormone. She's only on T4. She feels like garbage. And she said, do I feel weird saying that I'm actually glad you found something wrong, because I've been saying this to my doctor for years that something just doesn't feel right? And I'm like, no, I get that a lot. And I hate to say that you're all these things, but also we can fix this. Yeah. And you have to trend those labs, because you don't know what you're doing until you trend them. And I actually didn't start doing that myself until a few years ago, when I would go back and I had a little bit of adrenal fatigue. I had a little bit of a sluggish thyroid issue that I was working on. And I was like, I need to trend my labs. And I went back and I looked at what my OB ran with both pregnancies. Not a single OB appointment for lab draws that I ever get a TSH as a pregnant patient. And I'm like, whoa. So I can't even tell you what my labs were because I didn't trend them. Now, lesson learned, yearly, and I actually do them bi-yearly or twice a year now. Well, I will try my labs because I can see and feel the difference when I do that. So very cool to see that. I feel like I was going to say something about earlier what you said. Oh, the classes.
Oh.
Reminds me, funny story. When I was trying to do, I have done a lot of hormone classes since meeting Brandy. And that's what she keeps telling me, Mia, it's an art. Yes, you're going to add science, but it's an art as well. And it would just get me so frustrated because I would take all like thousands of dollars worth these hormone classes. And I'm like, Brandy, not a single person is doing the same thing. I'm like, so how do I know what I'm doing? And she's just start and you will get your feet wet and you will understand and fall into your groove and your niche of what's working best for your patients. Because when Brandy says people practice differently, my goodness, do they practice differently in the hormone world? And that can be scary at times and can be very turning off for some patients. My patient that I just called you yesterday for, her very first experience with hormone replacement therapy, her provider did estrogen and testosterone pellets as her very first thing, which is like, Brandy and I agreed. We're like, that was probably a bad idea. And when you look at those cases, you're like, then she was put on bio or synthetic after that. And it's, my gosh, this girl had one shot to have that bioidentical. Now she has a bad taste in her mouth. And we're slowly working on, okay, well, let's get off the synthetic. Let's try this again. Different routes, different reactions. Yeah. So it's crazy to hear when people say, I didn't tolerate the bioidentical. It's, well, your body makes that. So what didn't you tolerate? Was it the dose? Was it the route? Was it something compounded in it? Was it the way that it was made? Was it peanut oil? Like whatever the case may be. Yeah. But just remember, if you tried it and it didn't work, it just wasn't the right plan for you. And it takes time. As you said, you're like Mia, some patients can take months to get better, but it's better than years of misery. Absolutely. And you just have to ride that out.
Yeah. I think the other thing, just to piggyback on that, is that there's such a thing called the standard of care in medicine. And so like we as providers are taught the standard of care. And so in me too, I'm like this. I'm like, why can't it just all be the same? Because when you're treating a STEMI or when you're treating a URI, there is a standard approach to how you treat it, what differentials you look for in a diagnosis, what treatment plan you should do, what tests you should order. And so there's not like any set guideline. I mean, there's ideas, but it's always evolving. And I think thankfully we are headed in the right direction. There is a positive. We are headed in the right direction.
Yes.
Towards hormones. So.
We are. And another thing, because you said urinary issues, that is another big one. We have such a rise in UTIs and things like that for patients, for females. And instead of your 5th antibiotic this year, has anybody told you to try some vaginal estrogen? Because that can lower over 50% of your UTI reoccurrence. Imagine how many deaths happen from chronic UTIs, because once you get a UTI, you go sepsis, you're delirious, you fall off the bandwagon, and you don't get out of the hospital. Same thing with hip fractures. We see this all the time. I remember working with you in the ER, and we would just know. If we had a bad case that was going south, we would look at each other and be like, yep, this person is just not ever going to get out of this. And it was those things, the sepsis, the fractures, things like that, where you're like, gosh, the falling, because yes, it can affect balance and how you're having those things. I remember that one case with you, a little old lady walked into the restaurant, tripped. She goes out to every Sunday with her husband, tripped, brain bleed, flew her out, and she died. And I'm like, now you think of these things and you're like, just what if her balance was better? What if we could have prevented this? What if somebody told her to eat more protein and lift more weights at a younger age? Which is what I'm so die hard now for, because I'm like, you go back in time of every single patient you've ever treated who might have had a bad outcome, and you're like, the system could have protected her better, and we didn't, because we didn't know what else to do besides throwing another antibiotic on her, which is not always the best case. Not to crap on antibiotics. Right. They are needed in certain times in certain places, but there might be something better for that patient, and 100%. To really be an advocate for that. So great. So what she said, looking at trends over time, how you feel, not just a number on a page. And like we said, it's a single snapshot in time. Hormones are hard to dive into. So when someone comes to you and presents with all these symptoms, regardless of age, what are you like looking for to say, okay, it might be time? Or when do you consider that HRT might be good for somebody?
Yeah, so definitely the subjective or the patient report is the most important thing. Honestly, way more important than the numbers, in my opinion. We have to listen to our patients and really get a good, deep evaluation. I always spend a full hour with all my first-time patients, and I probably could spend 2.
That's awesome.
But yeah, it's important. And so you have to look at everything. You have to look at the labs. You have to look at the patient. You have to look at the symptoms. I would say it really is dependent on like how severe the symptoms are. Maybe we can get by with some lifestyle intervention and ways to better optimize our body before we add hormones. But if this woman's not sleeping, let's say, that's one of the main things that like we have to have her to sleep, or she can't heal or repair anything in her body. Yes. And so I think it really just depends on where they're at in the game. I will say, I say this often, but I swear perimenopause causes divorce. And I feel so bad for all these women. And I always encourage like them to bring their husband to their visit, because I think it just goes back to the basis that like men don't understand women and women don't understand men. And so Guys, give your women grace if they're in perimenopause
For
and learn
sure.
about it. And so work together to get it solved would be what I would tell you, because it should be a time where it's so much fun and you have this excitement back in your marriage. And sometimes that's just not the case that's happening.
Because animosity probably built up for years, because
Yeah.
sometimes you can go crazy over this thing, major mood issues. And I hear that very often. I've snapped on my kids who are grown, and they're like, I'm so mad at everybody in my life, including my husband. Everything he does pisses me off. And I'm like, well, baseline, I feel like that's always, but when you're in peri and post, it's much worse.
Yeah.
And so I totally get, that's a perfect point to make, that husbands be grateful and graceful for this transition, because they didn't choose this. And 100% of females, unfortunately, go through this cycle that is just deemed so normal. Tough it up. You're good to go through this. And you have no idea what's going in your body. Imagine if you've ever been pregnant, or husbands have a wife that's been pregnant and they cry for no reason. Like, that is basically in a nutshell. But you don't bash them. You're like, you're pregnant. I know what's going on. It's hormones. So why is it any different when someone is a grown woman and is lost all of her hormones abruptly or non abruptly? And to not say, listen, I know what's going on. I know that this isn't you. This is a hormonal fluctuation problem, and addressing that. So lots of different forms that we've talked about. So I know that you don't like synthetic. I don't either. Give me just a quick rundown of maybe some routes that you like to do. Why wouldn't you choose synthetic over bioidentical? Just sum that up for us.
Yeah. Well, I think the basis of that would be, why would you use a synthetic when you can use a product that's the same chemical structure as what we have naturally occurring in our body? That to me always is a safer option. And so that'd be the first and foremost what I would say. Routes get difficult, and I would say the best route for the patient is what they'll be compliant with, what they're actually going to apply, and what works best for them. And sometimes you need to change the route too. So sometimes I have patients that start on one product and we might change to something else because it's either not effective, or they're not compliant with doing it, or they just might not like it. And so in general, like, a lot of times you're going to see like the transdermal route probably being one of the most common, and it's a safe route because it's absorbed through the skin, so it bypasses the liver. And that leads me to like oral estrogen. There's bioidentical oral estrogen. It can be safe and effective, but there's a little bit more of a risk for blood clotting, and you have to watch the liver with that because of the first pass effect. And so it has to go through the liver first. So then therefore that increases potential risk for clotting. And so again, like, knowing your patient, knowing the risk, maybe if they are an older person and they do have some underlying cardiovascular disease or family history or personal history of any type of clots, I'm probably going to stay away from that.
Yeah. And to piggyback off that, you have to assess the patient as in its entirety, and they're not doing that. For example, I had a patient a month ago who was on oral estrogen and some progesterone and testosterone, all different routes, but the estrogen was oral. And I was working with her on detoxifying, and she had a sluggish liver. And I'm like, that is the last person I would have chose that route with. And I'm like, are you having some extra side effects because the route is the wrong way? So we switched her to transdermal, and then we're working on her detoxifying properties when she feels so much better on that state versus oral. And everybody is different. Also, to touch base on what Brandy said about risk factors, when you hear at higher risk for clot, it's a scary term to say, oh my gosh, I'm definitely not doing that. But if you've ever had a synthetic birth control, that's the same risk. If you've ever been pregnant, that's the same risk of clots. So you have to understand that informed consent can be passive aggressive in a way. So when your doctor can say, oh, those are dangerous, that's a very like passive aggressive thing to say, well, what is actually like absolute risk versus relative risk versus every other medication you already prescribed me that I'm already on? What are those risks that they didn't tell you? So that goes back to Brandy saying that they're very fear mongered because of, you really have to break open the data to say, what is that greater risk? Because if there's only, and like I said, I'm not even going to touch on breast cancer and things like that, but if there's only 1 or 2 extra cases per 10,000 patients, what risk is versus a lifelong of better longevity? Like, those are the risk factors that you need to look at the data and the evidence to show like it's way more fear-mongered than what it should be, which is why we had a massive gap in that. So
what's the risk of not doing hormones at all?
It is.
Their mental health state, they might be at risk for suicide if you don't treat their hormones, honestly. So there's a lot of risk-benefit analysis that definitely needs to happen.
For sure. Yeah. And we see it missing all the time. Okay, so key points to hit on that one. Like we said, perimenopause fluctuation. Menopause is low and steady state. So like Brandy said, typically transdermal would be the best preferred route to start off, lower risk panel or factors. Oral micronized progesterone often preferred, and monitor that, of course. Do this in the guidance of someone who knows what they're doing. And then all of the other modifiable risk factors. Be out in the community, engage yourself in community. We know that has better mental health, better release of good hormones, your dopamine and things like that have that community. Go back to the blue zones, though they live the longest life. Eat a healthy diet. Sleep is huge. Brandy said, if you're not sleeping though, we might have to address that first so you can address everything else. Because if you can't sleep, you can't do much. And I don't know if you're like me, where if my kids disrupt me a few times a night, my next day I'm like, who am I? Like, where am I? Like, I am just in a mood. So if you're doing that day after day after day and not sleeping month after month, we might have to assess that first with some support so you can do all these other things. Protein, increase your protein. Girls, track it. Females, older people, especially in pre and post, track it. That is, you want to make sure you're at least hitting 100 plus grams. They say whatever your goal weight is and body weight to consume that a day. That can be very difficult. Just aim for good sources of protein. Muscle, weight lifting. Lift heavy things for the love of the Lord, not your 8-pounders. If you have to start there, that's great, but you better work your way up because you have to have that stress in your muscles for your body to adapt, grow, and then you need more weights, and then adapt and grow, and then you need more weights. That is the muscle building that I'm talking about. I'm not talking about staying with an 8-pounder for the last 10 years that you've been working out. So adjust that as you grow and your muscles will grow. Like we said, avoid alcohol, caffeine, eat cruciferous vegetables. Those can absolutely help hormonal support. Girls, if you're still cycling, you can do seed cycling. You can do eating according to your cycle. There's great data out there to say, depending on what phase that you're in, to eat the foods that extra support that during that time. So that's a good one. Lower cortisol. We know cortisol is also a hormone that can affect insulin, that can affect every single hormone in our body, making sure that you're getting your stressors under control. Yes, I know it's easier said than done. Find what makes you happy and keep doing that. Assess liver function. If you can't metabolize things, you're going to be at greater risk for buildup and not being able to process even your own, let alone anything added to you. Magnesium is a great one to take at night. That can also help with sleeping. I usually recommend about 500 or so, maybe 1,000 based on their needs at nighttime. And then, of course, reach out for therapy. Do not suffer alone. Reach out for hormone therapy if that's something that you could benefit from. So, this is just open to discussion here. So when I hear it, because I just heard this the other day as well, my postmenopause patient saying, well, I was just told, let's just wait it out. What do you say to that? What are we waiting on?
Yeah.
They're gone.
Yeah, I'm not for that game.
Yeah.
There's no way I'm going through it without the use of hormones.
Yes.
If I'm being honest, just the literature is way too solid for for longevity reasons. I have women who want to come very late in life, and it's like, we've probably lost out potentially on the time to like remineralize bones and things like that and prevent dementia. So we have to. I would say the earlier you can intervene, the better. Not early. If you can do lifestyle things, great. But like when you hit menopause, that definitely is the time that you should be considering.
Yeah,
things,
when things are going down and
Yes.
you're neat. Because remember, yes, it's based on symptoms, but it's also based on if your levels are completely depleted, even though you feel okay. Do you want those extra risk factors later on in life? Because to me, just like Brandy said, I feel like you and I are going to be saying what everybody says on hormones, where you're going to pull them out of my cold, dead hands because they feel so good on them. Another person that I've really started to look into is Dr. Pam Smith. She's one of the gods of hormone replacement therapy, and she's 80 something. And when you look at her videos, you're like, you look so good because you kept up with your hormones. She very clearly states, I never needed testosterone. I always felt great. I never needed that. She's on estrogen and progesterone. She lifts weights. She's still doing her seminars, and she's 80 something years old. And I'm like, she looks like she can outrun a marathon for me.
Yeah.
So it really does make a difference to stay consistent with those things. And like Brandy said, start younger. Now, just because you're older and you feel like you might have missed that window, it doesn't mean that we still can't eliminate, or at least not eliminate, at least reduce your risk factors that you've already had brewing. It's never potentially a full hard stop too late, but just remember, the longer that life goes on without these, the more risk factors you're going to have for that bone density loss, osteopenia, osteoporosis, fractures, brain fog, mood changes, all the things that we need to make sure that we're benefiting from. We already talked about the surgical menopause, so we don't need to touch on that. So let's just briefly, actually, you know what? Let's go into men's real quick. For men, do you see more females than men?
Honestly, I would say it's about split. But
Okay.
I really enjoy taking care of women, but
Yeah.
I love taking care of men too. Men don't like to admit that they have what's called andropause.
Oh,
So,
let's get into this.
yeah,
All right,
yeah.
let's
So
hear it.
guys have hormonal decline too, but lucky for them, they don't really have the complete loss that we experience, So they're having just a steady decline. They also don't get the fluctuation that women get. And so they're becoming symptomatic because their hormones are lowering, but they're not dealing with this crazy shifts in how they feel, which can definitely be turn offish if you're the guy in the relationship.
Right, and
So-
your wife is becoming psychotic, and
Yeah.
you're stably declining.
Yes, yes. So in men, the natural aging process would create andropause. And so that's a natural decline of testosterone with age. There are the natural decline of testosterone, where any decline in testosterone would be considered hypogonadism. There's primary, there's secondary.
Sure.
This can occur at earlier stages in life, but this isn't typically what we're referring to right now. But this would be a general decline of testosterone related to aging. And just because I know that like Tim and Mia are so big into this, but like things like endocrine disruptors, like those things are triggering hormones to change very earlier in life than we've seen in past decades for men and women.
Yeah, I had a high 20-year-old patient with a testosterone of 300 and something, and I'm like, oh my gosh, what are you doing? Eating your Axe deodorant or something? Like the amount of stuff that he's probably exposing himself to in a daily environment. He worked in a factory. I'm like, oh my gosh, you're just a walking endocrine disruptor. And those are the patients that would have never gotten help for years. And I'm not saying medication is the first line of treatment in these patients, but like Brandy said, you have the natural aging process where they'll have a nice, slow, steady decline, but then you have a much earlier population that we're seeing due to these endocrine disruptors, vaping, alcohol, sleep issues, high stress life, factory jobs, things that are going to, things that are going to put you in these chemical based things where now you're living in an estrogenic state because as we were talking about a couple days ago when I called you and collabed on a patient where testosterone in men can convert to estrogen.
Absolutely.
So now you have men that are estrogen dominant, which is a crazy thing to think about. So, okay, so you do treat men a lot and you consider testosterone therapy. What are some of the symptoms that maybe you see in men versus women for that?
Yeah. So a lot of them actually will be very similar other than like obviously the main female ones versus the main male ones. But a lot of times they're going to complain of fatigue, exhaustion, a lack of motivation to get going, mental clarity or brain fog. Sleep can be an issue for them. Erectile issues, low libido, huge. Men, their testosterone is literally what makes them go. So it's their get up and go in the morning. Morning erection, loss of morning erection is a thing that happens as testosterone declines because testosterone is naturally highest in the morning. And so when you have a morning erection, that's actually a very good sign that your testosterone level is probably healthy.
Yeah. That's crazy.
Yeah.
That's crazy to think about. So you have this decline and then other risk factors that I know for men that we absolutely need to address. What are some of those comorbidities that you see, high blood pressure, things like that can absolutely affect their production or how they're feeling? Like what other metabolic issues that you see that you're like, let's work on this too as we replace?
Yeah. I think really all the same things for women and men. I really think it just comes down to like lifestyle. Even if you were adverse to hormones and didn't want to do it, like it would still be worth a discussion with Tim and Mia to see what can you change in your lifestyle to better your overall health, to make you perform and function to the best of your ability.
Yep.
If we need to add hormones, absolutely. But if we do only adding hormones but don't fix any of this, we're not going to fix the patient to the best of our ability.
Yes.
So we need to address everything, the whole patient. And so I think it's really important. Some of the big ones definitely that you got to watch with testosterone would be red blood cell production or secondary polycythemia, secondary to TRT. You need to watch their PSA and their blood pressure, and then the hematocrit goes with that. So those are the big ones that we want to watch. If you have insulin resistance, if you have diabetes, if you have hypertension and you're a male, men typically are more reluctant to seek care than us women are when it comes to a medical problem.
Yeah.
I tell all men care about their erection. So if your vascular system is not functioning well because you do have an underlying disease process or you do have some insulin resistance or you have hypertension, you're directly affecting that. Yeah. So it's better to, again, intervene early, fix whatever you can fix to optimize that, optimize blood flow so that you can have that for a long, long time. Right?
Bingo. And that is something that they don't address at the PCP because men will get treatment for this. They will. And honestly, they don't get testosterone as much as they should. They get the Viagra. They get the tadalafil first. But within that, there's no education to say that actually, given your age and what's going on in your erectile dysfunction, that is likely the first sign of metabolic dysfunction, vascular issues, and none of that is addressed. It's here's your Viagra and let me know if it works or if you need a higher dose. Like, I get it. I've worked on platforms that you're basically pill mills and hand out ED meds like they're candy. And there is a lot of ED out there, which tells you how many metabolic dysfunction, low testosterone, all the things that go together. So long story short with that one, make sure that you're looking at the entire picture because not one single medication is ever going to be the end all be all. I tell this with my patients with even the GLPs that are needed to jumpstart weight loss. This is not a Band-Aid. This is a crutch to help you fix your life, change your lifestyle, address underlying issues that will make your body function better as an entire system because I don't want you on medication for life. However, I have learned that the longer that I've been practicing this, that there are a few things that I will say that is okay for life and hormones is one of them because of the the longevity component of it, the reduction of risk factors of it. And I'm actually very thankful that I got into this world because it was like a big puzzle piece to me that it's almost like that, considering like a biohacking thing. Like, you want to live longer? You want to decrease your risk to lose your mind and end up in a nursing home? Like, you should probably replace what's missing. So very cool. Okay. So testosterone, what is your most common route for men?
So most commonly for men would be injectable. A lot of men use cream. There's pellets. There's other meds that you can use like enclomiphene to help increase your testosterone naturally. So there's a lot of different ways you can increase testosterone. Probably the natural things would be build muscle, like Mia said, lift heavy things, eat protein. Okay. Men will be like, what about this testosterone booster?
We're going to supplement out your way of a crappy lifestyle. Yeah, I say that all the time. It can help, but if you're not doing all the other things, you can throw the supplement right in the garbage. It's probably not going to make much of a difference. Now, for injections, typically sub-Q that you like to do versus IM for better steady states?
Yes. Now, I will do both. Again, I'm very much about the patient will be compliant with what they're comfortable with. And so sometimes we will change the plan based on what their need is, or maybe they've already came to me on a different thing. If they're not optimized, then I'm probably going to work at changing that. But yeah, I do subcutaneous more often.
Okay. And that's once, twice, up to 3 times-ish based on...
depending on the patient. I would say usually 2 to 3 times a week for subcutaneous injection. And if you're going to go IM, then it's a larger dose once a week.
Awesome. And how often do you see, or how quickly do you see that they start to feel better?
So usually you're going to start seeing things typically within 7 to 14 days for both men and women. But as you increase, we're going to probably recheck things around 6 to 8 weeks. I would say 3 to 6 months to start getting optimized. So the first 3 months are what I call a trial to see how your body's responding, to see how you're doing. We're going to need to recheck levels and then potentially change or alter dose depending on that.
Okay. Good deal. So there's that. And then you also have pellets, which are a little bit, I wouldn't say more invasive, although they are, but those are, your patients do well with that as well as your form of treatment.
Absolutely.
Okay. And then we have females and testosterone, which I did want to touch on. Is there anything else that you wanted to add with the men's section?
I think the only other thing that I was going to add earlier when you talk about lifestyle is that we have to meet our patient where we are. And I know Tim and Mia talk about this all the time. And I think this is so true because I've actually seen them live this where Tim says, oh, I'm human. I eat bad. I worked with them in the emergency room for 15 years. I know that they eat bad sometimes or did at least.
Yeah,
not now. And me too, right? So like, we have to start somewhere. So same thing with like hormones and lifestyle. Like I will say for sure that like I can help somebody start treating their hormones and that might give them the energy or the exercise or the motivation to start changing the things in their lifestyle where they might just completely lack the drive to get up and even exercise. But if we can give them that back a little bit, then they're going to start doing. And then every time you see them, you're constantly just like beating this into them. Let's go. What can we do to further optimize things? And so they'll start listening once they start feeling better and then they can be proactive. But all patients, you are your own best advocate, right? We cannot want it more than you want it. And I say this in the ER, and it's sometimes so frustrating because we just want what's best for our patients. But ultimately, like we can't want it more than you want it. And so you have to be your own best advocate. We're here to be the coach and we're here to help you, but not be a dictator in how you care for yourself.
I tell that to my patients all the time, especially the ones that are struggling a bit. I'm like, listen, I'm here as your support, but you have to pull that weight. And I just had a follow-up yesterday. A girl was pretty discouraged. It doesn't happen often, but we get some patients that are like, I'm just not feeling like this is working. And I go back to them, I said, how much protein are you eating? I'm not counting. How often are you exercising? I'm not exercising. How often are you eating processed food? And I'm saying, listen, I can give you all the tools in the toolbox that I possibly can, but you have to meet me where you're at. And I can't want that more than you. I want you to feel your best self. I want you to be able to be a grandma frolicking around with your grandchildren one day. Like I want that for you, but you have to want that for you. And that is where that discipline comes in place. And just like Brandy said, once you get the momentum and once you start to feel a smidgen better, it's like that snowball effect. And you're like, I never want to feel that bad again. And I see this with my thyroid optimization patients. I see this with my weight loss patients who are down 100 plus pounds. I have a couple of people down 200 pounds. Like those are life-changing things where they would have never started if they didn't have the right tools. But then it is up to you. You are responsible for that journey. And you are also responsible in keeping and holding on to a provider that is going to be your advocate as well. Tim and I have said this every single podcast. If you don't like your doctor, fire them. That doesn't mean that you're going out doctor searching and being that, I wouldn't say annoying patient, but that needy patient that's saying, you're not giving me exactly what I need. But that's saying that if your provider isn't open to collaborative care, like Brandy and I do every single day, if your provider isn't open to say, I might not know that, but I will find out for you. Or I think that you need this, but I'm not the person. Let's go and give you those resources. So number one, if you don't have a provider that's supporting you in this atmosphere and going through this life, you're gonna have problems, period. You're gonna have a stall. You're not gonna ever be optimized. You're not gonna be educated about what it truly looks like to live a healthy life. So you have to be your own advocate. We cannot preach that enough. Good. Anything else you wanted to add on the men's side?
No, I
Okay.
think that's good.
All right. So I want to touch on, I know we're running over, but we'll wrap it up here soon. Female and testosterone, because my goodness, do we get crapped on all the time? And we have, is it more testosterone than estrogen most times for females? We have more in our body than we think we do. And when we hear the hormone replacement with testosterone, we're like, well, that's a man's hormone. Well, no, we have it and we need it. And some people need it a lot. But tell us the issue with, well, there's no really testing for it, the FDA issues. What do you see in the barriers for testosterone for females?
Yeah. So there are many for females. A lot of times women come to me and they didn't even know that was an option, that they could get testosterone. And it does wonders for the body for a lot of different reasons, men and women. It's probably my favorite hormone.
I know. I was just going to say, you told me that last week.
I love them. I love all of them, and they all serve their purpose. But so I would think that the FDA thing for women is honestly the most cumbersome thing when it comes to this, because it's not FDA approved for the treatment of women. And so then that further goes into the lab thing, where this is, again, a sample size. This is not reporting optimal values in women. They're literally saying, we surveyed 200 women and these are the values we got. Every single lab is different on their reporting reference ranges. So it gets very confusing to try to interpret that. But yes, we women, we have testosterone, probably about 1/10 of the amount a guy has. Yeah. And they have estrogen in a reverse format. But testosterone, it's getting currently looked at for the approval of low libido for FDA protocol. And I hope and pray that it gets approved. Women can, for sure, that reason alone would definitely be hands down, but it can do a lot of things for like energy, mood, exercise, sleep. Really, I love it because it can help everything across the board. It's our body's own natural steroid. And so a little bit goes a long way in women. And you heard me, a little bit. Like, there's definitely a thing where too much is too much, right? Like,
for sure.
We don't want masculine women. So
Yes, absolutely. Yeah. And like Brandy said, the ranges. When you get a testosterone level on a female, there is nothing to go by. Like you have to go by their symptoms. You have to, get a baseline. So if you do start that and they said, I'm feeling great, you can monitor those levels. I think you said you like your patients between 50 and 80 or 50 and 75 or 50 to 100, whatever works best for the patient. But there's really no data or good data out there yet. I do think, like Brandy said, this is coming and that would be absolutely life-changing. I think a lot of us are pushing back on saying, redo some of these studies, start studying females with testosterone. It is a very needed hormone. We have it naturally. We also have depletion of it. We also suffer from this, and we can very much so benefit, especially in those patients who might need more muscle mass or clarity or mood issues or changes that they need some more support with. So it's an awesome one. And you typically do all three. So, depending on the patient, of course, but estrogen patches, progesterone, oral for the sleep issues, et cetera, and then testosterone as most likely a cream. Yep. And they tolerate that very well. That's only a few times a week. They can rotate sites if they want, whatever that looks like for the patient, but it can be very beneficial. But once again, lacking data, we have providers who said, oh, it's not FDA approved, I'm never going to do that. I'm like, oh my gosh, if the FDA was only up to speed on some things, that would be fabulous.
Insurance and our healthcare system is broken, if you didn't know the name.
But our podcast says it all, Health Without the System. We have to start preaching more advocacy for our patients, and that's our goal. There is not enough Brandy and I's in the world. There is not enough people there's not enough time in the day that I can sit down and treat hundreds of thousands of patients that need this. So this is what we do. We have this platform. We get this out and say, guys, please be an advocate. Talk to your provider. If that provider isn't listening and it probably is hormonal related, find somebody who can listen to your needs. I have referred so many patients to Brandy I get a patient, they upload labs, testosterone is low and very low, like 300 for a grown man at 65. And they're like, well, it's still within that range. I'm like, yeah, but it's like, it's not in that range. Like, you feel bad and it's at the very low end. So that's not optimized. And I'll send them to Brandy and they're like, yeah, of course they get treatment. And these PCPs are like, no, you're within my little bubble. I can't go out of this bubble. And it's like, gosh, we do such a disservice sometimes. So,
and that's not always the provider's fault.
No,
There's
it's
stuff
not.
within those guidelines, unfortunately, which is why sometimes you have to seek care other places. Yeah. And thankfully, too, for women, there are plenty of people like me and I. There isn't enough, she's right, but there are some people that are strongly advocating for like perimenopause and menopause hugely in our country, which is good. So hopefully that will be a positive. And if you are a provider who's in traditional medicine, like, we love you too. Get educated. Yeah. You know what I mean? If you're a PCP and you deal with women and men all throughout their life, or you're an OBGYN, like, this absolutely should be something that you're studying. Yeah. Do a CE on it. Watch the 2-hour video that the FDA just had about perimenopause and menopause.
Oh, I have to watch that.
Yes, it's phenomenal. It goes over all the benefits of hormones, and why the Women's Health Initiative was flawed. And it's a roundtable. It's awesome because there's literally,
cool.
there's internal med, there's an orthopedic specialist, there's women's health, there's a cardiologist. So they have physicians of all specialties represented at this roundtable. And it's
so
awesome.
cool.
Yeah,
That's
you
so
got to
cool.
watch it. Maybe we can link it in the show notes or something, but it's good.
Yeah, things are changing. And honestly, things are changing because more people are speaking up, because we are realizing that what you're taught in school will never nor should ever be the end all be all, because we know that science and education in our system is very far behind. And if we are not up to date saying that doesn't seem right, if you are not questioning science, you're probably in the wrong spot. And yes, as providers, like, you should always want to question science to say, look at this patient, look at their true risks, look at their true benefits. What am I actually scared of? And then present that to your patient. I'm going to go over I say that all the time to my patients. This is my plan of care that I think that we should do. These are the potential risks. These are the potential rewards. What do you feel like you want to do? And we don't see that. And that's where we have that huge gap. And unfortunately, we don't have time to go into what the Women's Health Initiative study was, but it did a major disservice to patients. They were using conjugated equine estrogen or mare's urine, essentially, and using that as a synthetic form. And they saw a small spike in cancer and breast cancer. And they're like, halt, everybody stop. And within 1 day, we have 50% to 80%, or probably even higher than that, abruptly stopped at hormones, because everybody got so scared with this. And that's a very, very summed up area of that study, because there was a lot more that went into
that study.
A lot of flaws, but also a lot of benefits that they didn't even point out. Like one being that if you did have breast cancer, you had a better survival rate. You had no increased risk of death if you had breast cancer being on hormone replacement therapy, versus patients that had breast cancer that were not on hormone replacement therapy. You were at greater risk of dying and not surviving that versus being on hormones, bioidentical. So those are the things that they don't pull out, but that didn't hit the news. Like none of that hits. So they take these little bits and particles and they launch it out into social media. And we know that social media has its major downfalls. Of course, perks, we're getting out free education. Downfalls, it's very easy for somebody to pick a segment and say, oh, I'm a provider and that sounded scary, I ain't doing that. And cherry pick data. And that's what we want to avoid.
Everybody stopped using their hormones overnight, essentially, after that study, right? But the last 20 years, we've gone without hormone replacement therapy for the majority of women, and yet breast cancer rates still go up.
Higher,
so
exactly.
How can you blame it all on that? I'm not sure.
Right.
No, but
like you said in the beginning, nursing homes are saturated. We got UTI deaths, we got fractures, and people falling down, and we'll never survive that. Like, you have so many things that we're seeing elevating, and all case mortality. And it's, what did we just do the last 20 years? Like, how much of a disservice did we do to the population? And I think we're starting to see that. And I fingers crossed, and I pray that this changes, because I can't even imagine going another 20 years knowing what I know now and not being an advocate for these patients to speak up, male and female, to say, you are not alone. This was just a massive missed gap of education, and we're going to get back to it. And it's not so scary. Awesome. Well, this was a amazing podcast. Now, where can they find you? We're local. So do you do some telemedicine in Ohio?
Yep.
Okay. So where are you found, or where are you located at, and how can anybody get a hold of you?
All right. So my office is in White House, Ohio. I also do telemedicine patients for Ohio only at this point. My office phone number is 419-877-8159. You can also find me at renewed-therapeutics.com. You can find lots of information there. I would love to help you if I can. Absolutely. And if I can't, I'll point you in the right direction.
Exactly. So, it's all about that toolbox, man. You got to find those providers that are not afraid of collaborative care. So awesome. Well, this was fabulous, Brandy. I thank you so much for joining. I have a feeling this is not going to be our only podcast, so stay tuned for some more fun girl chit chat, and we can talk about all things hormones and whatever else we want to talk about. So thank you for listening, guys. For all you first-time listeners, and for anybody coming back, thank you very much. We appreciate the support. Please share and follow for any single person that you can benefit from, aka any single female in your life who is going to go through this eventually. Just send them this podcast. Give them the knowledge. Knowledge is power. But thank you very much. Just a reminder, this podcast is for informational purposes only and is not medical advice. It is not a substitute for professional care, diagnosis, and/or treatment. Always consult with your healthcare provider before making any changes to your health routine. Remember that you have the power. Join us in next time to get the knowledge. Thank you very much, and until next time, thanks, Brandy.
Thanks for having me.